Julian, there's a couple on the front row next, but Julian, you've got the mic.
It's Julian Cater from Canaccord. 2 questions for me, please. You've obviously had an inorganic strategy as well, an organic strategy within healthcare. Can you perhaps expand on what capabilities you feel you don't still possess within healthcare, what you'd potentially look to acquire over the next 3 years? And then secondly, in the Leicester case, my understanding is that there's a certain element of partnering with Capita on that contract. Can you just say what services they are fulfilling and whether you look to develop those own services yourself so that going forward you wouldn't need to partner with them? Thank you.
Shall I maybe start, Phil? I mean, I think, as Phil's illustrated, health is an enormous marketplace. We sense within that a migration from acute care to community care. So I think our focus will be on sort of catching that ball, if you like, on the community side rather than bulk up in acute services as our principal area of operation. Advantage actually sort of punches a bit above its weight in terms of its scalability. You know, Phil showed you the map there. We feel we've got an infrastructure that we can grow quite strongly organically, and one of the things we liked about the business actually, which is uncharacteristic of this sort, is that it's grown organically rather than inorganically. It's not a sort of a collection of mom and pops that have been put together and needs integrating. So we feel we can actually do a lot organically, but I guess we'd be looking at specific opportunities to expand footprint and the sort of range of services. Anything you'd like to add to that, Phil?
The 2 that I think would be really advantageous, where it's probably weaker than other sectors, is the mental health and the learning and disability sectors. So I would have thought those would be 2. Whether we can do that organically or whether we'd need to acquire, I think we'd have to have a look at.
Yeah. To the second part, obviously Capita, very valued part of our supply chain on Leicester. The issue there we were looking to overcome was one of track record in terms of estate transformation. Clearly you take everything on its merits, but if we've now got estates transformation under our belt, that would tend to suggest that that's more a core skill than it was. But you know, we look at the market on a sort of a case-by-case basis, I think it's fair to say.
Thank you.
Okay, I think there are a couple on the front row. Perhaps if we could... Andy, you had one as well, did you? Yeah.
Good morning. It's Andrew Nussey from Peel Hunt. Again, just a couple of questions. You obviously say there's a guarantee in there for cost savings to the client in Leicester. I guess what happens if you don't deliver them, but equally what happens if you do over-deliver on them?
Okay, so if we under-deliver on them, then we don't make the return that we should do. So we've actually guaranteed those. But it's core capability that we have. So it's facilities management outsourcing. It's what we've been doing for the last 15 years. So it's something we have absolute confidence we can do. And the level of inefficiency in Leicester was quite something to behold, as you can probably see from some of the statistics. So I think we've got absolute confidence we can do that. If we overperform, then there's a sharing mechanism with us and the trust in terms of the benefits that arise from that.
I think it's fair to say the transformation piece, our obligation is to generate ideas and business cases. Clearly, the trusts have their own governance and need to take responsibility for making decisions, and our risk, or the sort of risk of nugatory work and nugatory business case building is capped to a manageable level. But I think that'll be where the real money is in this transaction if they can implement some of those transformational structural choices.
And secondly, in terms of advantage, as far as I can see, there's no local authority related spend in the mix at the moment. Is that an opportunity going forward?
It has potential. I think what we want to do is concentrate on the NHS clinical services. We think that's a big market. I think the regulation and compliance in the NHS is as a level that's appropriate, and I think we're more comfortable with that. I think we think that the social care market, I think, is far less strong in terms of those kind of principles, and I think also the barriers to entry are far less as well. So I think the competitive dynamic in that sector is going to change in the next few years.
I mean, big picture, clearly the budgetary segmentation is one thing. The money, the interventions that citizens need is another, and those things don't always line up, whether that's health, social services, justice, welfare. We're trying to piece together capability, broadly across that space. I mean, this may be a topic that Andrew might be able to comment on in terms of some of the thinking going on within the opposition at the moment around how social services and health do interact with each other to deliver hopefully a better quality outcome for the citizen at a lower cost to the taxpayer. But it's certainly there's connectivity there.
One of the things we found with Advantage is that most of the patients, although they're getting clinical services from us through NHS funding, they're also in receipt of services from the local authority as well. So from a customer receiving end of things, joining those things up makes absolute sense.
Okay. Andy, did you have a question? And then Joe, I'll come to you.
Andy Brown, Pamela Gordon. Two from me as well. Just in terms of, you mentioned Southampton and Leeds potentially coming out. I mean, how imminent is that news, and how large are they relative to Leicester? Okay,
so Southampton is actually out now. So they've actually put a European Journal advert out. Leeds hasn't yet, but will shortly. And Nottingham is out, and the pre-qualifications just happened.
In terms of scale?
So Nottingham is slightly bigger than Leicester. Leeds is dramatically bigger than Leicester, and Southampton's probably slightly smaller.
But they're all, significant chunks of business over a long period of time. So.
Yeah, I mean, the kind of driver you can work them through is just by the population. The population drives the spend broadly. So although there are some demographic differences, generally southeast, southwest, there's a bigger per capita spend. In basic principles, is that which drives the clinical spend around each demographic.
Thank you. Second question, just on the estates management side of things, you said Leicester 3 acute hospitals going down to 1.
No, they've got 3.
Oh.
If you were designing an acute solution for them now, I don't think you'd put 3 hospitals into Nottingham.
So you're not about to see Interserve close hospitals and grab all the wrong headlines?
No.
Right, thank you.
Although estate rationalisation is a nice word for shutting stuff down.
Yeah. But it's association, isn't it? I mean,
absolutely.
You deal with the association.
We're here to implement our clients' strategies,
Thank you. On clinical services, I would have slightly expected Mighty and Mears's dom care businesses to be in that list of competitors. Why aren't they?
They're not, because if you looked at who their actual customers, who are funding it, they are predominantly local authorities. So one of the things that's different is that the funding for most of the services that Advantage are providing is coming from the NHS. So they're clinical services as opposed to Anara and other businesses where it tends to be the funding is coming from the local authority, and it tends to be social care services. So they tend to be less clinically based. So, for example, if you look at the most of Advantage staff are NHS registered nurses. So the actual level of care is quite different.
Aren't they both clinical, but one's higher up the acuity chain? Isn't that what I think
I think that's one of the whole debates around what's
I think they both care, but they're not both clinical.
Right. Okay. And a follow-up question, just on Leicester. I understand that there are sort of KPIs that will drive your profitability. Is there, and I'm sure you will deliver those, but is there a floor that protects your downside as well?
Yeah, so the deductions are just limited to our profit. So they can't touch our cost base.
Thank you.
Okay. Howard in the front row, and then Eleanor. I think one on the front, and then Kevin, was that you with your hand? Yeah, come to you next. Yeah.
Okay. Howard Seymour from Nemis. Adrian getting off far too lightly, so I've got a couple for you actually, if you don't mind.
The first I was contributing, Howard, personally.
The first one is just on the, when you were talking before about the vision for the company, you mentioned the developing further footprints in support services UK. Can you talk a little bit more about that, areas that you'd look to going into?
Well, yeah, I mean, clearly we've moved into welfare. We want to be in justice and are gearing up for the probation and rehabilitation competition, as well as whatever services are finally decided to be packaged up and outsourced in terms of the prison estate itself. We've talked about some further penetration into healthcare. I guess across most of our verticals, actually, there's a long-term sort of expectation that competition will expand further, so that could apply to defence as well as to local government services. I mean, some of the sort of service packages that we're looking at now, Phil, are a lot broader than they were across the board, really, aren't they?
Yeah, I think education and training is one as well that's potentially of interest.
So really, it's this theme of frontline service delivery, rather than enabling that by looking after buildings nicely. It's to actually step into the spotlight, as it were, and deliver the service itself.
Okay, thank you. Secondly, you mentioned obviously the 2015 targets, etc., and looking through the profile of that, is it fair to assume, without numbers, that on the construction side of things you'd expect to deliver those towards the 15 as opposed to 14?
Yeah, I mean, I think any upturn in demand that's meaningful in construction, we would hope and expect to see that manifest itself maybe next year. But with the way that we account for construction contracting, there's a lag in profit recognition for the obvious risk management reasons that we're very familiar with in the market. So we'd probably expect a back ending to that contribution.
Thank you. And just one last one for Tim, really, on sustainability. Can you talk me through how you would roll that out internally? Because it would strike me that it's very important from the personnel point of view, and what the experience is to date of doing that.
Yeah, I mean, the rollout, it's like any good internal communication and change management process. You need lots and lots of communication, from the big top-down arm-waving messaging via webinars right down to the hearts and minds individual small work groups. We've got about 200 people in the organisation who have some sustainability element to their job already through what they're doing with clients. So part of the knack has really been to empower these people and to get them out there evangelising and being ambassadors for it. And the other knack is to get some hard metrics, data collection, data mining, and gradually to feed those sort of targets into people's incentives so that they can see the relevance of their day job to the bigger picture.
Thank you very much.
Okay. Kevin, I think you had, yeah.
Just in a way trying to understand. Is this?
It's working. Yeah.
Just trying to understand how you piggyback the healthcare services off your more sort of traditional expertise in FM management. If you take something like Leicester, in practice, if part of your role is suggesting to the council that actually we can shift X amount of revenue from acute into community, does that automatically include or preclude your business being part of that? Because presumably there are, some levels of compliance, etc., etc. So I suppose what I'm asking is, through mechanisms like Leicester and maybe Southampton, etc., etc., does it just ensure that you get an opportunity to bid for any shift in that healthcare workload, or is it entirely separate to the sort of position you have on the FM side of things?
It varies from project to project. For Leicester, it very specifically is included in it.
Included.
It is included in it.
So you would have, if you put forward a viable proposition of shifting that revenue.
Yep.
It would be incumbent on you to actually provide those services as a group.
Yeah, we have the opportunity to do that. If we wanted to go and test the market, we could do that as well. But now we've got an advantage. We've got the capability to do it ourselves in-house.
Okay.
So we put together the business case for them. The business case is part of the Leicester framework, and then we then share the benefits of that with them.
I think it'll be case specific how health economies want to manage that. But I suppose strategically we're saying we can be part of demand generation in terms of downscaling, helping trusts effect that structural change from secondary to community, and we can be part of the supply side of the community demand when it arises. We'd like to, being both sides of the market is generally an advantageous place to be.
Okay, thank you.
In terms of the projects that come to market, the other two projects that are in the market at the moment, Southampton doesn't have that, whereas Nottingham does as well. So at the moment, everyone's got the discretion whether they include it or not.
Right.
I think what will happen is people will look at and see how well Leicester actually performs. That will be the proof of the pudding.
Well, I think it's no secret these trusts in Leicester are challenged. They're not doing brilliantly. They have a lot of improvements to make. So that's clearly a positive motivational factor for change, but the spotlight is very much on whether this works within the health sort of world. And I think as Phil says, a lot of the future decisions will probably be taken in light of the experience that we achieve or don't with these clients.
It's probably early days on Leicester, but what do you perceive as the limits to how much revenue shift that you can make between hospitals?
If you look at the usage, and they're currently at around 36%, and the average in the market is around 50% in terms of clinical usage of the facilities. You've got 14% there already. I mean, we've done a space utilisation survey that shows that 20% of the estate just isn't physically used at all. So it doesn't take a lot of great intellect and thought to think actually we can do something with that 20% in terms of either stop doing anything to it or realise some value from it as well and use it for other things.
And this is fully serviced space.
Yeah.
That's empty.
Thank you.
Okay. Right. We've obviously worn you out with that part of the presentation, which is great. So we'll move on.